Okay, so this is chapter 43, oxygen needs. Then the next one is respiratory, and the chapter 45 is rehabilitation. So oxygen is the biggest one, and then that rolls right into respiratory needs and so forth. So I think this is actually really great that we're doing these three today because it really helps out with the clinical science as well. Oxygen itself is a gas, or O2. It has no taste, color, or odor. It is a basic need required for life. We have to have oxygen to survive. Death occurs within minutes if breathing stops. But if breathing stops and the person is brought back to life or starts again breathing, brain damage and serious illnesses can occur without oxygen for long enough. The amount of oxygen in the body is affected by illnesses, surgery, injury, but you are going to possibly be assisting patients with oxygen needs. The respiratory and the circulatory system, the circulatory is that veins and arteries and so forth, system must function properly for the cells to get enough oxygen. That's how it's delivered. Disease, injury, and surgery can affect these in the intake and use of oxygen itself. The altered function of any systems that affect the oxygen needs. Oxygen needs are affected by the respiratory system and open airways needed. The circulatory system, the blood must flow correctly. The red blood cell count, it must contain hemoglobin to deliver that oxygen. The nervous system, this is where diseases and injuries can affect the respiratory muscles, making breathing difficult or impossible. Also, as aging happens, the respiratory muscles weaken, and those patients don't breathe as fast. Exercise, the oxygen needs increase with exercise. Fever, the oxygen needs increase as well. With pain, the respirations or breathing pattern increase to meet the needs for more oxygen. Also, some medications or drugs depress the respiratory center in the brain. Smoking causes lung cancer and COPD. Allergies cause severe swelling and can close the airway. Pollutants can damage the lungs, even long term. Nutrition, so iron and vitamins are needed to produce those red blood cells that carry the oxygen. And then alcohol in excess reduces the cough reflex, which increases the risk of aspiration as well. The respiratory function involves three different processes. The air moves in and out of the lungs for the inhalation and exhalation. Oxygen and CO2 are exchanged in the alveoli in the base of your lungs. And then the blood carries oxygen to the cells and removes CO2 from them. The word hypoxia means not enough oxygen, and so the cells do not have enough oxygen. The cells then can't function properly. Anything that affects the respiratory function can cause hypoxia. Early signs are mainly going to be confusion, dizziness, restlessness, and disorientation. Some of these patients present just like a UTI. They're super confused. They're saying things out of their head that they don't normally say, and really they just have a super low oxygen number. Hypoxia definitely threatens life. Some important things for you to remember for the next coming up weeks here are that normal adult respirations are 12 to 20 per minute. If it's outside of those, then you should let the person you're following know that. Infants and children have faster respiratory rates, but normal respirations are quiet, are effortless, and regular. Okay, you shouldn't be able to outwardly hear them unless they're having abnormal breathing. Both sides of the chest should rise and fall equally. Otherwise, you could have a problem. So tachypnea, that means that there's rapid breathing, so anything over 20. Bradyapnea is going to be slow breathing or anything less than 12. Apnea itself is the lack of breathing or absence of it, so not breathing at all. Hypoventilation means that they're not breathing enough, therefore causing hypoxia and so forth. Hyperventilation is where the respirations are rapid and fast. And so this causes it where the CO2 can't get out, and that's why people that are hyperventilating or breathing too fast actually pass out. So this is what breathing patterns are going to look like that I just described on a monitor. So tachypnea, really, really fast breathing. Brady is going to be slow. Apnea, no breathing at all. Hypoventilation is slow and shallow. Hyperventilation, fast again. The last two here are Cheyenne, Stokes, and Kussmaul. These two breathing scenarios here could be near the end of life, and the breathing significantly changes near the end of the life. If you have an opportunity to help a patient near the end of life or to see one, normally hospice is involved. But the hospital nurses or CNAs will tell you, oh, I know they're getting close. It might be in the next hour or two because of their respirations. They're going to hear them kind of like outwardly gasping for air. That's kind of some of those Cheyenne Stokes, and then Cosmo as well. What happens in both of those is they actually start out really fast. I mean, so sometimes it like looks good and the patient does a little bit better, but then eventually that wears out and changes their respirations to too slow. Okay. The term dyspnea means difficult or labored or painful breathing. Orthopnea means that they can breathe deeply and comfortably only when sitting. Bias respiration or rapid and deep respirations followed by 10 to 30 seconds of apnea, so no breathing at all. An altered respiratory function may be acute or chronic problem. Acute meaning short term, chronic meaning even with treatment, it might not ever go away. You should report any observations that you make with breathing patterns promptly and accurately. Quick action is needed to meet the patient's oxygen need, and measures are taken to correct the problem and to prevent it from becoming worse. The doctor could order a chest x-ray, a lung scan, a bronchoscopy. A thoracentesis is where that pleural space I'm going to show you a picture is punctured with a large needle. Pulmonary function test. Any of you guys ever had one of those done if you're asthmatic? A pulmonary function test. They're not all that fun, but typically have those done once or twice a year to see the amount of air moving in and out of the lungs. And arterial blood gases as well. So blood gases you're possibly going to see drawn in the ER and then also the ICU. And so kind of keep that in mind. I wonder if they're needing something. They just gave me some looks. Pulse oximetry measures the oxygen concentration in arterial blood. The normal range on a pulse ox is 95 to 100. You are going to be using pulse oxes, and on there is something called this pulse oximetry. It's also called pulse ox. It's called O2 sat, not stat. Okay, if you hear a patient's family member saying stat, just go with it with the family, but please don't say O2 stat. That's not what it's called. It's called O2 sat. Okay, there's no extra T in there. And so, pulse ox, oxygen level, if they're asking you to get that, that's when you're going to put the finger device on. And that not only gives you your oxygen number, that's supposed to be 95 to 100, but it also typically gives you the pulse as well. So the pulse is going to be the number with the heart beside it. This sensor attaches to a finger, a toe, an earlobe, or a nose or forehead. Don't ever really use the thumb, okay? Try to get the fingers nice and warmed up. Put one in the pulse ox sensor. Let it go for a few minutes and see if you get a number in between 95 into 100. Respiratory disorders can cause the lungs and the bronchi and the trachea to secrete mucus. So sputum production, cough production can cause problems as well. Sputum specimens are studied for blood and microbes and abnormal cells. To get enough oxygen, air must move deep into the lungs because that's where the air exchange between oxygen and CO2 happen in the alveoli. But disease and injury surgeries can prevent that from reaching there. Pain, immobility, so not moving around at all. And narcotics are going to interfere with deep breathing and coughing. And so sometimes the secretions can collect in the airways because you can't cough them up. And this provides a place for microbes to grow, and infection becomes a quick threat. To follow measures with oxygen needs, these measures are commonly placed in the patient's care plan. It could tell you how to position the patient. Usually a patient sitting upright and then bent over like this man is here in semi-Fowler's position is that easier breathing position. Also, they might need frequent position changes, helping them, assist them in deep breathing and coughing exercises because that's going to help move air to all the parts of the lungs. Coughing is going to remove that mucus, and exercise is going to promote oxygenation. If you haven't seen this before, you should pay attention. It is an incentive spirometry, or IS. This is used to help the patient improve from either pneumonia after surgery. It's to help really for deep breathing exercises and to prevent infection from happening. The goal here is to improve lung function. That atelectasis is going to be prevented or treated. Atelectasis is a collapsed lung that can happen very quickly. Oxygen is a drug, okay? So the doctor orders the oxygen, when to give it, the amount to give it, and the device to use. Some people need oxygen all the time. Some people need oxygen through the night. Some people need oxygen just with exercise. So the doctor has to order that. Others may need it for chest pain and shortness of breath, and you cannot actually just give oxygen, okay? You're going to help provide safe care with oxygen. If they have it ordered and they already have it ordered, you can help put the nasal cannula under the face and so forth, but you're not going to just put oxygen on a patient without having a doctor's order. The sources of oxygen, this is a wall outlet here. The oxygen comes in through the wall, and so it's piped into each patient's room. This is a portable oxygen tank here. It can be placed at the bedside. You can go to the shower with them. It can be transported by wheelchair and so forth. Also, there's an oxygen concentrator, and it's on the pictures on the next slide. The machine removes the oxygen from the air. There's a liquid oxygen that is a portable unit filled, and this is kind of one of those bags that the patients carry with them, the oxygen sources. So the picture here is of an oxygen concentrator, a portable liquid oxygen unit, and so this is going to be the small one down here of that you see frequently being carried in bags. And then one thing I want to show you on this one and this one is that they have water, distilled water hooked up to the oxygen, and they should do that all the time because that makes it humidified oxygen. Otherwise, when you have oxygen running through the patient's nose and the mouth, it really, really dries out those mucous membranes. So humidifying that air really helps. So this here is a picture of a nasal cannula. This is what you're going to see most often in the places you guys are going. And then these non-rebreather masks and simple masks as well. The nasal cannula is going to be the most common up there, pretty user-friendly, and just the most common overall oxygen delivery device. Okay? Moisture, when you have masks and so forth, can build up underneath those masks, so you need to try to work on cleaning that. Keeping it clean and dry will help the mask stay on better. Oxygen can be given during cannula during meals. If it's on an oxygen mask during non-meal times, then we can switch it over to a cannula just for a meal and that they could eat easier. And then another example of oxygen might be an oxygen hood over top of the patient as well. The oxygen is coming in through this area here. Oxygen flow rate, so that's the amount of the oxygen being delivered. It goes anywhere from 2 liters to 15 liters. If you're up past 15 liters, then they probably need a different type of oxygen device, probably going to be moved to an ICU or something a lot more serious, okay? The nurse of the respiratory therapy can set the flow rate with a flow meter after they receive the doctor's order. And the nurse in the care plan tell you the person's flow rate. You can check the flow rate, read on there what it says. Is it at 2? Is it at 4? Is it at 6? It's a pretty easy measuring device to read. But you can let them know if the flow rate's not what you thought it was supposed to be, if it's too high or too low. And the nurse or respiratory therapist should adjust that rate. Oxygen setup, if it's not humidified, it really dries out those mucous membranes. Distilled water needs to be added to the humidifiers. Bubbling in the humidifier means it's good, it's working. Oxygen safety, you're going to assist the nurse with oxygen safety, but not a therapy or not apply it to the patient. You do not give oxygen, and you must give safe care. So while ago I was talking about pulse ox or O2 sat, and that's going to be the number on here. So all of these, how you turn them on is you press that button right here. Okay, that turns it on, put it on the patient's finger. A red light should occur in between where the patient's finger are. One of the numbers is the oxygen, and it's going to say SpO2. Okay, and then the other number should have a heart by it, and that's going to be your patient's pulse. Okay. This picture B here is going to be an infant pulse oximeter, and it's a little bit different, but reading the same thing. This is some documentation and charting that what they did with the patient. They made the patient deep breathe 5 times, cough 2 times, and how the patient was laying on his back. And then at the end, they made sure and documented call light within each. All right, let's see where we're at here. A few more minutes. Let's move on to respiratory, which is it flows right in from oxygen needs, and we'll go to break and then come back and do rehabilitation. So respiratory support and therapies, chapter 44. Rolls straight from oxygen therapy. Some patients, they need a little bit more than this oxygen that we just got talking about, more than that mask, more than that nasal cannula. So some patients need artificial airway, suctioning, mechanical ventilation with a mechanical ventilator, and chest tubes as well. Anyone here ever seen a patient with a chest tube or on a ventilator? Okay. So that can be pretty scary and so forth. There's more than likely you're not going to see a lot of this at clinical, but there's still, of course, a possibility. Often very ill patients need respiratory rehabilitation to recover from problems affecting the airway and lungs. and complex procedures and equipment. Artificial airways, they're going to keep that airway open and patent. They're needed when disease happens, injury, secrete too many secretions, aspirations. If the patient can't breathe on their own, then they're going to need an artificial airway as well. The patients can be semi-conscious or unconscious for having artificial airways, or when the patient is recovering from anesthesia. Intubation, that term means that they are inserting an artificial airway. These ways are going to be the most common ways. An oropharyngeal is going to be inserted in through the mouth and into the pharynx. And in the tracheal tube, so an ET tube, it's going to be inserted through the mouth or nose and into the trachea. And then a cuff is down here, keeping that in place. A tracheostomy tube, this is what the mannequins in there have right now, is a bunch of tracheostomies. So it's an artificial airway down here at the lower neck area. And these can be permanent or temporary. So you might see patients with a scar from a cut there from previously, but they've been able to be closed up and can breathe normally later in life. So with the tracheostomy tubes, this is what they're going to look like, the parts to them. And so this is the part that you're going to see on the outside, this flange here. This is the part that goes into the patient, kind of making that airway down to the pharynx, okay? So this is showing you suctioning the airway. This is showing you the gauze and then the ties. Those need to be changed out when they're wet, or when they're not Velcroing anymore. And then this is showing you about that you should be able to put like a finger underneath there for tightness, okay? With artificial airways, vital signs and pulse oximetry are done very often. We should observe for hypoxia, so not enough oxygen at all times. If an airway comes out or is dislodged, you should tell the nurse immediately. Frequent oral hygiene is needed for these patients, so they might need those gauze things in their mouth. They might just need some of that because it really gets dry with all that oxygen. You should comfort and reassure the patient even if they're unconscious. And follow the care plan for communication methods and allow the call out within reach at all times. A tracheostomy, that's that surgically created open into the trachea. While I say it's surgically open, it can happen in emergency situations like in the back of an ambulance, or it can happen also like in the middle of a code situation. If there's something blocking in between here and here, and it's lodged in there, then we know that we can cut right here and get straight into the airway, okay, with a quick scalpel. But otherwise, then they're surgically created. The tube must not come back out, or that's extubation. A loose tube can damage the trachea, so it needs to be a good fit. There's different sizes that we trial. The tube must remain patent, so open at all times. If able, the person needs to cough up their secretions, otherwise suctioning the patient is going to be needed. With a tracheostomy, you should call the nurse if you're seeing any signs of hypoxia, so that not oriented, the confusion, or respiratory distress, or if the outer cannula comes out. Nothing must go into the stoma except that cannula. Tracheostomy care involves cleaning that inner cannula, cleaning the stoma, which that's the actual site on the skin, and then applying clean ties over a foam collar to prevent infection. Secretions can collect in the airway, and those secretions are what cause airflow not to be able to go down. They can provide an environment for microbes and interfere with that oxygen and CO2 exchange. Suction is needed for patients that can't cough on their own, or their cough is too weak that they can't get up those secretions, because we really need to be able to get those up. These routes are used to suction the airway, so through the mouth and the pharynx, then through the nose and the pharynx, and then the lower airway as well if we have an ET tube or a tracheostomy, and down into the lungs a little bit. With mechanical ventilation, this is going to be the picture here. So a machine beside the patient's bedside, and they have an ET tube down or a tracheostomy. So this is completely, their breathing is completely ran by the machine there. This is needed for people with weak muscle effort. They can't breathe on their own. An obstructed airway, damaged lung tissue, drug overdose, and nervous system disease and injuries. An ET or tracheostomy needed is a half tube for mechanical ventilation. Alarms sound when something is wrong. If you see one of these, you're going to notice that the alarms go off all the time. If there's just a tiny secretion in there, it alarms. If the patient tries to override the machine with breathing on their own, which is good, then it alarms and so forth. So they alarm quite a bit. Do not reset the alarms. The patients needing those mechanical ventilation are very, very ill. Air, blood, and fluid could collect in the pleural space. And this is where I was talking about having to stick that needle into the chest here. So in between the lungs themselves and then the rib cage is something called the pleural space. And if air or fluid get in this space, then that creates a huge emergency. And this is when we have to put a chest tube, has to be put in to release that air or the blood or the liquid or anything like that, okay? So also there could be something called a pleural effusion, which is the escape and collection of fluid into that space. So what we're going to insert is going to be, we're going to cut the scalpel into that pleural space, insert a tube to drain that air or blood or liquid, and that makes sure that the lung doesn't collapse anymore as well. If air can't reach the affected alveoli, then we need one of these as well. And so it really can create a lot of problems. So if you've ever seen a patient with a chest tube before, this is pretty much exactly what it looks like. This chest tube is inserted into that pleural space and then hooked to this machine. It's not a machine, it's a plastic piece, okay? And it's a plastic piece, it doesn't have any like buttons you push or anything like that. It's really a drainage thing and it's hooked up to section from the wall. The doctor is the one who inserts the chest tubes to remove the air, blood, or fluid. Alright, you guys just want to do this last one, it's not very long, and then we can, okay. And then we can go to break. Alright, so rehabilitation needs. When I say rehab or rehabilitation, I'm not talking about drug rehab or anything like that. When I'm saying rehabilitation or rehab, and I noticed this right saying this too, she's talking about physical therapy, occupational therapy, speech therapy, okay? She's talking about patients with disabilities that need assistance, maybe not lifelong, but maybe temporary disability, that they need help learning how to do something again to get them back to normal. Body function with a disability can be affected by disease, injury, or surgery. Some of them might include birth injuries or birth defects, like spina bifida, cerebral palsy, and so forth. Often though, a lot of times more than one function is lost with a disability, but the losses can be temporary or permanent. A disability is defined as any loss or absent or impaired physical or mental function. They can be acute, so short-term, or chronic, where it's a long-time problem. The person may depend totally on others for their basic needs, but the degree of the disability is going to affect how much function is possible. The goals of the healthcare team with disabilities are going to include prevent and reduce the degree of the disability and to help the person adjust to it. Rehabilitation itself is defined as the process of restoring the person to his or her highest possible level of physical, psychological, social, and economic function. They're going to focus on improving the ability to go back to work or to do self-care as well, to be able to feed yourself, to be able to brush your own teeth, to shower on your own, and so forth. Sometimes we just get by with improved function, but sometimes that's not possible either. So then the goal changes over and it begins that we don't want to make any loss anymore. So prevent any further loss of function and so forth. Some patients return home after rehabilitation and some continue on going to community centers, nursing centers, and so forth. Restorative nursing care helps the person regain his health, strength, and independence. There are different levels of this, but the main goal here is to help maintain the patient at the highest level of function and to prevent any unnecessary decline in function. So things like bathing, oral hygiene, dressing, eating, everyday things that you and I take advantage of, those are things that we need to make sure that they can do correctly. Bladder training and control, positioning, mobility, communication, maybe they had a stroke and now they have aphasia, or the disability or loss of ability to understand language, and then cognitive function as well. These two pictures here are going to be options that could modify a person's life if maybe they have something going on. So this is making it where they can hold a spoon here. It's just strapped into this restraint here, and then the call light as well can help people ring to people and so forth when they need assistance. These are some more assistive devices, but you need to keep in mind that a disability has physical, psychological, and social effects. The patient's going to have to adjust to those in a lot of different ways. Abilities, so the things they can do need to be stressed, and the complications need to be prevented. This right here is where they accommodated, say, a cutting board here. They added these nails to it because you don't take advantage that when you're cutting something, one hand is holding it down and then the other one is cutting. So this is going to help hold whatever it is down, and then if you have just one hand, then you can still cut. Physical aspects, so when rehabilitation starts, the person first seeks health care, and then complications need to be prevented. Contractures or pressure injuries need to be prevented during the care and so forth, so it can better you during that. The following may be needed: good alignment, turning and repositioning, range of motion exercises, good skin care, bladder training, and assistance with those activities of daily living. Self-help devices. So in this picture here, it's showing this patient using a transfer board. Maybe they lost like one side of their body to a stroke again or something like that. But this transfer board makes it where they can still slide themselves on over into the bathtub and so forth. This gives them a lot of independence. You don't think about that, oh, I can step into the shower by myself, until you have to have somebody help you, and that's really embarrassing. So also rehabilitation can include prosthesis, so there's artificial limbs and so forth, assistance with nutritional needs, speech therapy, communication devices, and mechanical ventilation as well. Psychological and social aspects, the self-esteem and relationships may suffer because there may be an effect in function and appearance of the patient. The patient may deny their disability. They may expect therapy to just fix their problem and quickly. Successful rehabilitation depends on the patient's attitude, and boy, oh boy, that is true. If they have a good attitude, they're going to do so much better, and so forth. You should really focus on what they can do, so their abilities and strengths and psychological and social needs are a very big part of the care plan as well. The economic aspects: if a patient just quickly becomes disabled, they weren't before, the goal needs for them to become gainfully employed again. This could put a huge stressor on their life. The rehabilitation team is a lot of different people. It's the family, the doctor, the nursing, the healthcare team, so the physical therapy, occupational therapy, respiratory therapy. But the patient is really the key team member here. The focus is going to be regaining the function and independence. Families should provide support and encouragement, and they can help with home care as well. But your job as a CNA is going to be to focus on promoting the patient's independence. So helping them out with that, helping them but not doing for them, or getting them to a point where they were not having any decline in care. Common rehabilitation programs include cardiac rehab, brain injury rehab, spinal cord, stroke rehab, respiratory rehabilitation, musculoskeletal, and rehabilitation for complex medical and surgical conditions. So this is showing, helping a patient get into a car here. The patient may transfer to a nursing center or rehabilitation agency after the hospital discharge. Some of these assisted living residents and adult daycare centers can provide these services as well. You guys are going to notice when you go to the long-term care centers that there may be some younger people there. It may be for mental, it may be for physical disabilities. And so you're going to see that. There's a few young people at some of our facilities, and they might share with you what their disability is eventually and so forth. But just think about them. That could be your mom's age or even younger, or maybe your age, that could be in some of these facilities. You need to think about all the time the quality of life of the patient. We're trying to improve that for them. To promote the quality of life, protect the right to privacy, encourage personal choice, protect the right to be free from abuse and mistreatment, and learn to deal with your own anger and frustration. Encourage activities. There's a lot of activities, especially in the afternoons at these facilities. Provide a safe setting. Show patience, understanding, and sensitivity. So as I'm saying that, like I said, they like to do a lot of the activities after lunch, you guys. So after lunch, our big thing might be we're getting in there at 12 or so, and we're helping them finish up their lunch or get their lunch. Then they probably need to go to the bathroom. And then I would encourage you guys to all go and help with the activities. So like Ellsbury, they've been bowling at least once a week, having like a bowling league. They have like a bingo. Go play with them.
Sometimes they have like Christmas.
Oh yeah, Christmas things. I mean, sometimes Ellsbury's drinking beer and they're having a poker party. They really are. They're living their life too, right? So, when I say drinking beer, I mean they're having like one or two. They're watching a football game, a baseball game. They're trying to give them the most normal life as possible. Does that make sense? So, not just Ellsbury, that goes everywhere. I'm just saying they really, really have a lot of fun with the patients. Please be there for them, play games with that. That changes it up for them. They really